Good day, I'm Dr. Alan Bongat from the section of gastroenterology, and today I'll be discussing diseases of the esophagus and the stomach. Let's start with a brief review of the anatomy of the esophagus. The esophagus is a muscular hollow tube about 25 centimeters long that carries food and liquids from the pharynx to the stomach, and it does so by peristalsis. So the esophagus has four layers. So from inside out, we have the innermost, which is the mucosa. This is composed of non-keratinized stratified squamous epithelium. Next, we have the submucosa. This is where the glands and connective tissues are located. And then we have the muscularis propria. This is the muscular layer that is mainly responsible for the peristalsis. So it's very important in the transport of food and liquids down to the stomach. And it has muscle types. No? For the upper third, it consists of skeletal muscles, which are voluntary. The lower third contains smooth muscles, which are involuntary. And the middle third contains mixed skeletal and smooth muscles. And the outermost layer contains the connective tissue that anchors the esophagus to the surrounding structures in the mediastinum, and that is the adventitial layer. Now, equally important are the sphincters. We have the upper esophageal sphincter. This is located just between the pharynx and the esophagus. And the main muscle for the upper esophageal sphincter is the cricopharyngeus muscle. So the upper esophageal sphincter opens during swallowing, and it prevents air from entering during breathing. And we have also the lower esophageal sphincter. This is located at the junction of the esophagus and the stomach. And this serves as a physiologic zone of high pressure at the gastroesophageal junction. It relaxes during swallowing to allow food to enter the stomach, and it also prevents reflux of gastric contents from the stomach up into the esophagus. As with all other conditions, we start with a careful history taking. We look for symptoms that would suggest esophageal disorder. The most common esophageal symptom is heartburn. This is characterized by a burning retrosternal discomfort, so you feel it behind the sternum, and it arises from the epigastric area and may radiate up towards the neck. Heartburn is an intermittent symptom, and it is most commonly triggered by large or fatty meals, by lying down after eating, by caffeine, alcohol, or certain medications, and is also strongly associated with gastroesophageal reflux disease. Next, we have regurgitation. This is the effortless backflow of gastric contents, such as fluid or partially digested food, up into the throat and into the mouth. So the patients with regurgitation report a sour or burning fluid in the throat or mouth that may also contain undigested food particles. And unlike vomiting, it is not preceded by nausea and retching. So it is effortless. It should always also be differentiated from rumination, which is recently swallowed food being regurgitated and then re-swallowed repetitively for up to an hour. Next, we have chest pain. The chest pain of esophageal disease is kind of similar to pain of cardiac origin, like there may be radiation to the back or to the arms. So you should be careful always in patients with chest pain. So esophageal pain is usually felt as a substernal pressure or squeezing sensation in the mid-chest. And for patients with chest pain, we should always rule out cardiac causes first, as heart disease is more common and is definitely more life-threatening. Next, we have esophageal dysphagia. This is having that feeling of food sticking or food slowly moving after the initial swallow. When the symptom is dysphagia, it is important to distinguish if the dysphagia is episodic or constant, if it's progressive or static, or if the dysphagia is experienced only for solid foods or for both solids or liquids. These informations can help you narrow down your differential diagnosis. So, also you have to differentiate it from oropharyngeal dysphagia, wherein the symptom is more of difficulty in initiating a swallow. Dysphagia is different from our next symptom, which is odynophagia. Odynophagia is defined as pain on swallowing. So this is usually due to mucosal injury or ulceration of the esophagus. And it is more common with pill or infectious esophagitis than with reflux esophagitis. Next, we have globus sensation. This is also known as globus pharyngeus. This is the feeling of a lump or fullness or sometimes tightness in the throat. This is not related to swallowing and it has no true blockage. Although it may also be associated with GERD, and it is also seen in those with anxiety disorders. And then next we have water brush. This is the sudden appearance of a sour or salty tasting fluid in the mouth. This is usually due to excessive salivation resulting from a vagal reflex triggered by acidification of the esophageal mucosa. The difference between water brush and regurgitation is that water brush is mostly saliva and not gastric contents. And this occurs as a reflex and not from actual gastric fluid coming up. Let's now proceed to the diagnostic workup of patients presenting with esophageal symptoms. This is the esophagogastroduodenoscopy or EGD, or we sometimes call it upper endoscopy or simply gastroscopy. This is the most useful test for the evaluation of the proximal gastrointestinal tract. So this procedure is done using a long flexible tube with a video camera in the end, and the tube is placed into the mouth and then down to the throat, and then it's slowly pushed through the esophagus and the stomach and then into the duodenum. So video images are seen on a monitor, so you have direct visualization. Endoscopes also have an instrumentation channel through which biopsy forceps or injection catheters for therapeutic agents such as balloon dilators or instruments for hemostasis or removal of mucosal lesions can be used. During endoscopy, you can take tissue samples for biopsy if you see anything unusual like a mass or any irregularity in the esophageal mucosa. You can remove foreign bodies such as food that may be stuck in the upper gastrointestinal tract. You can perform therapeutic interventions like dilation of strictures or measures to stop gastrointestinal bleeding. And these are the advantages of EGD. You directly visualize the area and it also has therapeutic capability. And since this is a direct visualization, other advantages of endoscopy in terms of detecting abnormalities are an increased sensitivity for the detection of mucosal lesions, like small ulcers may be missed by CT scan or contrast radiography. And number two, it can also increase sensitivity for the detection of abnormalities which are mainly identifiable by color. So examples are Barrett's metaplasia or vascular lesions. Radiologic examination of the esophagus is done mainly using contrast radiography, particularly contrast or barium esophagogram. The patient will be asked to ingest a contrast material. It can be barium or water-soluble contrast. And then x-rays are taken as soon as the contrast material reaches the esophagus. When it comes to detection of strictures, contrast radiography is more sensitive than EGD because EGD can miss subtle strictures. So this is an example of an esophagogram showing an area of narrowing here in the distal esophagus. Also, if there is a fistula such as a tracheoesophageal fistula, it will be more evident as you will see contrast material coming out of the esophagus and going somewhere else. Contrast radiography can also demonstrate reflux of contrast media. Hiatal hernia can detect mucosal granularity, erosions, and ulcerations. But of course, EGD will be more sensitive for these cases since EGD is under direct visualization. Next, we have endoscopic ultrasound. As the name implies, this is a combination of endoscopy with ultrasound. Although there is a dedicated scope for this, here in the Philippines, only a number of hospitals have this and only a few gastroenterologists are trained to perform this procedure. So in EUS, you have an endoscope with an ultrasound transducer at the tip. And this creates detailed images of the esophageal wall and nearby structures. EUS is particularly helpful in esophageal conditions if you want to determine the depth of the tumor, so like in staging of esophageal CA. Plus, it can also guide fine needle aspiration of image structures that are nearby, like lymph nodes or maybe tumors that are closely related to the esophagus. If you want to check the motor function or the motility of the esophagus, like in conditions such as achalasia or diffuse esophageal spasm, both of which I will discuss later, then the gold standard would be esophageal manometry. This is a diagnostic test that measures the pressure and the coordination of muscle contractions in the esophagus during swallowing. So during this procedure, a thin pressure-sensitive catheter is passed through the nose and down to the throat and down to the stomach, and this catheter contains multiple pressure sensors along its length. And then the patient is asked to swallow small sips of water while the machine records the esophageal peristaltic waves and the lower esophageal pressure. So this test basically tells us how well the upper and lower esophageal sphincters and the esophageal muscles work, like if there are weak contractions or incomplete relaxation of the lower esophageal sphincter. Next is reflux testing. This is used to diagnose gastroesophageal reflux disease. But we know that GERD is a condition that can be easily diagnosed clinically or just based on the presenting symptoms of the patient. But in patients who have atypical symptoms such as chest pain, cough, or those in whom the diagnosis of GERD is uncertain, then reflux testing will be very helpful. So, how is reflux testing done? You insert a thin catheter with a pH sensor through the nose and down to the distal esophagus. And then the sensor records acid levels continuously for 24 hours while the patient goes about his normal activities. It then measures the number of reflux episodes, the duration of acid exposure, and most importantly, the association between the presumed reflux event and the symptom of the patient. So the patient is asked to press an event button when the symptoms occur. I will now be discussing the more common conditions affecting the esophagus, and this will be our outline. One of the structural disorders of the esophagus is hiatal hernia. Hiatal hernia is a herniation of the viscera, most commonly the stomach, into the mediastinum through the esophageal hiatus. This is the opening in the diaphragm through which the esophagus passes. Normally, the lower esophageal sphincter and the gastroesophageal junction remain below the diaphragm, and this helps prevent reflux. But hiatal hernia can occur due to factors such as age-related weakening of the diaphragmatic hiatus, obesity, pregnancy, chronic coughing, heavy lifting or straining, or anything that can raise the intra-abdominal pressure. There are 4 types of hiatal hernias. Type 1 is the most common, comprising of 95% of all hiatal hernias. We also call it sliding hiatal hernia. In this type, the GEJ and the cardia, which are normally below the diaphragm, are displaced upward. Types 2 to 4 hiatal hernias are paraesophageal hernias, wherein it's the fundus of the stomach that herniates or is displaced from a localized defect in the phrenoesophageal membrane. Paraesophageal hernias are less common, but they can be more concerning. So for type 2, the GEJ remains fixed at the hiatus, then you have a part of the fundus herniating. You combine types 1 and types 2 hiatal hernia, and you have type 3 hiatal hernia. So here, both the gastroesophageal junction and the fundus herniates through the hiatus. And then the type 4 hiatal hernias or type 4 paraesophageal hernias is associated with a large defect in the phrenoesophageal membrane, so organs other than the stomach herniate into the mediastinum. So you can see here a part of the colon herniating into the mediastinum. So how do we manage hiatal hernias? For sliding hiatal hernias, if the patient is asymptomatic, because this can be seen on routine endoscopy, then it does not require any treatment. For those who are asymptomatic, the usual complaint is reflux, so we give treatment for reflux, and this will be discussed later. For paraesophageal hernias, especially types 2 and 3, the stomach may twist as it herniates, and this can lead to gastric volvulus and even strangulation of the stomach. And because of this risk, surgical repair is often advocated for large paraesophageal hernias. For type 4 hernia, this is associated with the high risk of complications, so surgery is advocated. Next, we have rings and webs. So for rings, a B-ring is a thin membranous narrowing at the squamo-columnar mucosal junction, so this is also called lower esophageal mucosal ring. It can be present in 10 to 15% of the general population and are usually asymptomatic. A specific form of lower esophageal mucosal ring is what we call the Schatzki ring. Here, the diameter of the lumen is less than 13 millimeters. And with this diameter, in general, not just for esophageal rings, but for other conditions of the esophagus as well, patients usually start feeling solid food dysphagia. Schatzki ring is one of the most common causes of intermittent food impaction. So it is also known as the steakhouse syndrome because meat is the typical instigator. Here is an example of a Schatzki ring on endoscopy, and on contrast esophagogram, you will appreciate a thin area of narrowing just above the gastroesophageal junction. Esophageal webs are usually seen in the proximal esophagus and can be of congenital or inflammatory origin. So you will notice that the lesion is not circumferential, unlike the esophageal ring. But like the ring, most are asymptomatic, and this can be seen in 10% of the population. But if they do cause narrowing of the lumen, just like this, then they can cause intermittent dysphagia to solids, similar to Schatzki ring. When symptomatic, webs and rings are treated with dilation. So this is done during endoscopy and guided by fluoroscopy. We have an option of using a balloon which is inflated to a certain diameter for 30 to 60 seconds. And the other option is by the use of a Savary dilator, where we use semi-rigid rods to dilate the area of stricture. So after the dilation, the strictures usually open. The next structural abnormality of the esophagus is esophageal diverticula. These are pouches that form in the lining of the esophagus and are usually caused by increased pressure in the esophagus or by external forces pulling on the esophageal wall. Esophageal diverticula are categorized by location. The most proximal is the upper esophageal diverticulum or hypopharyngeal, particularly the Zenker's diverticulum. At the lower end of the esophagus, we have the epiphrenic, which is the most common. Both epiphrenic and Zenker's diverticula are false diverticula. They involve herniation only of the mucosa and submucosa through the muscular layer of the esophagus. And in the middle, we have the only true esophageal diverticula. We have the mid-esophageal diverticulum. Zenker's diverticulum develops in the hypopharynx. So again, this is in the upper esophagus. It occurs in the setting of a stenotic cricopharyngeus muscle, and the exact location is an area of natural weakness that is just proximal to the cricopharyngeus. So this is known as the Killian's triangle. As you can see here, it is the area just above the cricopharyngeus muscle. You have here your Zenker's diverticulum. It is believed that abnormal pressure during swallowing causes dehiscence of this muscle, leading to formation of a Zenker diverticulum. Zenker's diverticulum are usually asymptomatic, but if the diverticulum is large enough like this, there can be retention of food and saliva in this area, so patients usually have symptoms like dysphagia, halitosis, or can be at risk for aspiration. The diagnostic modality of choice for esophageal diverticulum is barium swallow. Here you will appreciate the diverticulum in the proximal esophagus, and this is done during the barium swallow. Treatment is by surgical diverticulectomy and cricopharyngeal myotomy or transoral esophageal marsupialization. As mentioned, mid-esophageal diverticula is the only true diverticula in the esophagus. It is also called parabronchial diverticulum because being in the middle part of the esophagus, it is in close proximity with the bronchi. And sometimes it's also called traction diverticulum because it may be caused by traction from adjacent inflammation, so from the lungs or the bronchi, by conditions such as tuberculosis or histoplasmosis. Epiphrenic diverticula are often associated with achalasia, esophageal hypercontractile disorders, or distal esophageal stricture. Like the Zenker, mid-esophageal and epiphrenic diverticula are often asymptomatic until they become large enough to be able to retain food and cause symptoms like dysphagia and regurgitation. Symptoms attributable to the diverticula tend to correlate more with the underlying esophageal disorder than the size of the diverticula. So for large diverticula, this can be removed surgically, usually in conjunction with myotomy if the underlying motility disorder is identified. For structural disorders of the esophagus, we also have masses, so esophageal cancer. Squamous cell carcinoma is still the more common type globally. This is usually seen in the proximal esophagus, and the risk factors are smoking, alcohol consumption, caustic injury, and HPV infection. In Western countries, adenocarcinoma has become the more common type. And this is due to the high prevalence of gastroesophageal reflux disease and obesity, which are risk factors for Barrett's esophagus. And Barrett's esophagus is a risk factor for adenocarcinoma. So, adenocarcinoma are usually seen in the lower esophagus. Even if esophageal cancer is less common than colon cancer, esophageal cancer generally has a worse outcome. When a patient presents with dysphagia initially to solid food only, and then later on they would have difficulty tolerating even semi-solids or liquids, especially if this is associated with weight loss, then always suspect malignancy. Imagine a tumor in the esophagus slowly growing in size until the lumen is already obstructed. Associated symptoms may include odynophagia, iron deficiency, cough from tracheoesophageal fistula, hoarseness from recurrent laryngeal nerve injury, and when these respiratory symptoms are already present, they could be suggestive of locally invasive or even metastatic disease. Benign tumors can also be present, but they are uncommon and are usually discovered incidentally. So examples are gastrointestinal stromal tumor, leiomyoma, squamous papilloma, and others. A congenital anomaly of the esophagus affecting adults is heterotopic gastric mucosa. This is also known as esophageal inlet patch. So this is a focus of gastric type epithelium in the proximal esophagus. So it's like an area of ectopic gastric tissue, and on endoscopy it appears as a well delineated salmon pink area on the wall of the upper esophagus just below the upper esophageal sphincter. Most cases of inlet patch are asymptomatic, so when they are often found or discovered incidentally during endoscopy. However, since this is an ectopic gastric mucosa and we know that there is gastric secretion in gastric mucosa, acid secreted by this tissue can lead to symptoms like difficulty swallowing or having a fullness in the throat or globus sensation. We now go to motility disorders. Esophageal motility disorders are diseases that are due to esophageal neuromuscular dysfunction. The major entities which we will discuss are achalasia, diffuse esophageal spasm, and we will also include here gastroesophageal reflux disease. So for motility disorders, since the problem is motility, the dysphagia is usually to both solids and liquids. Achalasia is a condition characterized by progressive loss of ganglion cells in the myenteric plexus of the esophageal wall, and this leads to failure of relaxation of the lower esophageal sphincter, and this is accompanied by a loss of peristalsis in the distal esophagus. This is believed to be autoimmune in origin. Now, on the left side of the photo, you have normal peristalsis and normal LES relaxation and closure. Then, you have gradual destruction of the myenteric plexus and impaired relaxation. So we now have an esophagus that is just beginning to dilate. During these early stages of achalasia, symptoms may be mistaken for the usual gastroesophageal reflux disease. But then with further loss of myenteric plexus, there will be more impairment of the LES relaxation and abnormal esophageal emptying, and this will cause symptoms such as dysphagia, regurgitation, chest pain, and this is the time that you will try to manage with balloon dilatation, which I will show you later, and this will usually open up the LES but maybe temporarily. Achalasia is diagnosed by barium swallow or by esophageal manometry. So on barium swallow, the appearance of a dilated esophagus with poor emptying is appreciated, and there is also tapering at the lower esophageal sphincter, giving it what we call the bird's beak appearance. Since achalasia is a motility disorder, manometry will really show the impaired lower esophageal sphincter relaxation and the absence of peristalsis, which actually are the diagnostic criteria for achalasia. In addition, manometry identifies early disease before esophageal dilation and food retention, so it is the most sensitive test. Endoscopy should also be done, but this is mainly to rule out other etiologies such as tumors or benign mechanical strictures of the gastroesophageal junction, and not to mention, of course, that one of the treatment options for achalasia is balloon dilation by endoscopy. The treatment for achalasia are directed at reducing the lower esophageal sphincter pressure so that gravity and esophageal pressurization permit esophageal emptying. LES pressure can be reduced by pharmacologic therapy, pneumatic dilatation, I will show you this one on the next slide, or by lower esophageal sphincter myotomy. And this is by means of submucosal endoscopy or laparoscopic surgery. Pharmacologic therapy are not really very effective, but these can be offered as temporizing therapies. So we have nitrates or calcium channel blockers, we have botulinum toxin, and phosphodiesterase inhibitors. This is pneumatic dilation of achalasia. This is one of the most commonly used procedures for achalasia. This is the same one used for esophageal rings and webs if needed. Again, this is done using endoscopy combined with fluoroscopy. So you will see here the area of narrowing at the gastroesophageal junction. So in achalasia, you have an LES that fails to relax. So you position the balloon across the lower esophageal sphincter. And the goal in pneumatic dilation for achalasia is to forcefully stretch muscle fibers in the lower esophageal sphincter. And this is to reduce the outflow resistance and then allow easier passage of food into the stomach. So the major complication is perforation, but it has an incidence of around 0.5 to 5%. Aside from pneumatic dilation, the only other durable therapy for achalasia is LES myotomy. Before, LES myotomy was done only through laparoscopic surgery, but an endoscopic approach to LES myotomy has become increasingly available, and this is called peroral esophageal myotomy or POEM. Not all gastroenterologists perform this because you need special training abroad to be able to do this. The goal is similar to that of pneumatic dilation, that is to reduce the outflow resistance in the lower esophageal sphincter. And this is done by creating a tunnel in the submucosa of the esophageal wall through which the circular muscle of the LES and the distal esophagus are transected with electrocautery. So this procedure has similar efficacy with surgical or laparoscopic myotomy, but this is more advantageous since it is more minimally invasive, so the recovery is more rapid and there is no surgical disruption of the diaphragmatic hiatus. For the surgical approach to achalasia, the most common surgical procedure is laparoscopic Heller myotomy. The response rate is 90% for laparoscopic Heller myotomy at 5-year follow-up. So this is similar to that of pneumatic dilation. In Heller myotomy, the muscle of the lower esophageal sphincter is cut to decrease the resistance of the LES. And then usually it is performed with partial fundoplication, in which The fundus is wrapped around the lower esophagus to prevent acid reflux after the procedure. Another motility disorder of the esophagus is diffuse esophageal spasm or DES. This is a rare condition. In contrast to achalasia, there is normal LES relaxation, but there is abnormal esophageal contractions which are simultaneous and uncoordinated. The usual presentation is esophageal chest pain with heartburn, intermittent dysphagia to solids and liquids, and regurgitation. Since the problem in DES is abnormal esophageal contractions, 24-hour manometry is the best modality to diagnose DES as a cause of non-cardiac chest pain. On manometry, there is uncoordinated or spastic activity in the distal esophagus, spontaneous and repetitive contractions, or high amplitude and prolonged contractions. Endoscopy and barium swallow can also be done to rule out any kind of inflammation and masses in the esophagus. And on barium esophagogram, DES has a characteristic corkscrew or rosary beads appearance, which reflects abnormal contractions that leads to the curling of the esophagus. Pharmacologic therapy are not really very effective for DES, but once the medications that are on trial are nitrates, calcium channel blockers, and botulinum toxin. We now go to the discussion of gastroesophageal reflux disease or GERD. This is one of the most common conditions that we as gastroenterologists see every day. So, according to Harrison's, 10 to 15% of adults in the United States are affected with GERD, and the numbers are increasing. In the Philippines, there are no exact numbers, but roughly around 10% of the population. These numbers are important because GERD can lead to adenocarcinoma. GERD is defined by the American College of Gastroenterology as the condition in which the reflux of gastric contents into the esophagus results in symptoms or complications. The diagnostic modalities that are often used are endoscopy and reflux studies. Three dominant mechanisms of gastroesophageal junction incompetence are recognized. First is the transient LES relaxation. This is a vasovagal reflex that's usually triggered by gastric distension. This is the most common mechanism. It accounts for 90% of reflux in normal subjects. The next is LES hypotension. This is where the resting pressure is too low to keep gastric contents from entering the esophagus. And the third would be anatomic distortion of the GEJ, such as hiatal hernia. Aside from the three dominant mechanisms that were already mentioned, there are also other factors such as impaired esophageal clearance, elevated gastric acid secretion, impaired salivary gland function, impaired mucosal defense, and delayed gastric emptying. And these are the factors that are known to exacerbate reflux regardless of the mechanism. The most common symptoms of GERD are heartburn and regurgitation. Less common are dysphagia and chest pain, which should always be investigated. Other symptoms of GERD can sometimes include a globus sensation and water brush, and diagnostic evaluation should always be considered if patients present with extra esophageal symptoms or atypical symptoms such as cough, laryngitis, asthma, or dental erosions. These complications of GERD are usually seen in those individuals who have GERD for a long period of time. Erosive esophagitis and strictures are not that common now because of the effectiveness of medications, particularly the proton pump inhibitors. If with erosive esophagitis, long-term PPI would be very beneficial. If with stricture, there may be a need to do dilation. While the incidence of erosive esophagitis and strictures have decreased, the incidence of Barrett's esophagus has continued to increase. This occurs in 5 to 15% of patients with reflux esophagitis. So Barrett's esophagus is a change in the cell lining of the esophagus. Normally, the esophagus is lined with squamous cells, but in Barrett's esophagus, these cells are replaced by columnar cells. So this is also called Barrett's metaplasia. And the significance of Barrett's metaplasia is that it is a risk factor for adenocarcinoma. So adenocarcinoma occurs in 5% of patients with Barrett's esophagus, especially when it involves a long segment of the esophagus. On the left is a normal distal esophagus on endoscopy. But in Barrett's esophagus, you will see salmon-colored mucosa extending proximally from the gastroesophageal junction. And when this is seen on endoscopy, you suspect Barrett's, so you take tissue samples. The biopsy will then show you specialized columnar metaplasia instead of the normal squamous cells in the normal esophagus. For the treatment of Barrett's esophagus, first we have the medical management. We use proton pump inhibitors. There is evidence that aggressive anti-reflux therapy can result in partial regression of the metaplasia. So PPIs are usually given indefinitely. For the surgical approach, surgery or esophagectomy used to be the gold standard treatment for those with high-grade dysplasia. But nowadays, the role of endoscopy for these conditions has really evolved, and we can now perform endoscopic mucosal ablation therapies for the management of high-grade dysplasia. So here is an example using endoscopy. The abnormal cells containing the high-grade dysplasia are ablated without the need for surgery. After ablation, of course, surveillance has to be done using endoscopy. So let's now go back to the discussion of GERD. So for the treatment, lifestyle modification is very important. So we advise weight loss if the patient is overweight. We advise diet. You advise the patient to avoid acidic and refluxogenic foods such as alcohol, chocolates, citrus, peppermint, and coffee. We advise them to avoid large meals, maybe at least wait for 2 to 3 hours after a meal before lying down, as well as elevation of the head of the bed so that we can prevent reflux symptoms. The goal in pharmacologic management of GERD is inhibition of gastric acid secretion. While this does not really prevent acid reflux, as what happens in gastroesophageal reflux disease, it still improves symptoms of reflux and allows mucosal injury to the esophagus to heal. The mainstay is proton pump inhibitors. So PPIs, this has been mentioned several times already, and you will keep hearing a lot more about this as we go on with this lecture. Examples are omeprazole, esomeprazole, pantoprazole. These are more effective than the other option, which is histamine 2 receptor antagonists, although both PPIs and H2 receptor antagonists are superior to placebo. For the PPIs, no major differences exist among the PPIs, and only modest gain is achieved by increased dosage. As for the surgical approach, this is rarely done for GERD, but the best option is laparoscopic fundoplication, where the proximal stomach is wrapped around the distal esophagus to create an anti-reflux barrier. We now proceed to esophageal conditions that are inflammatory or infectious in nature. The most important is eosinophilic esophagitis. This is one condition that is increasingly being recognized, and this is a chronic immune antigen-mediated condition, meaning it is caused by the body's own immune system reacting to something it recognizes as foreign, which is the antigen. Eosinophilic esophagitis is diagnosed based on the combination of esophageal symptoms and esophageal mucosal biopsies, demonstrating eosinophilic predominant inflammation. And sometimes, the endoscopic appearance will help, but not all the time. Eosinophilic esophagitis should be considered in patients with dysphagia. This is the most common symptom, more specifically dysphagia to solid food. The solid food can be impacted, and this may be caused by strictures, which is a complication of long-term eosinophilic esophagitis. There may also be chest pain and abdominal pain. Nausea and vomiting may be seen. And it is also important to note that an atopic history of IgE-mediated food allergy, asthma, eczema, or allergic rhinitis is present in the majority of patients. So always check the past medical history of patients. The characteristic findings on endoscopy include loss of vascular markings. You have multiple esophageal rings. You have longitudinally oriented furrows and with whitish exudates. We take biopsies for histologic confirmation, and as mentioned, there would be eosinophil predominant inflammation with at least 15 eosinophils per high power field. Treatment of eosinophilic esophagitis often start with proton pump inhibitors. PPIs can improve the inflammation in half of patients with eosinophilic esophagitis, so we still start with the PPIs. Additional first-line therapy is swallowed topical glucocorticoids. This is effective in at least 50% of patients, but recurrence is observed usually after stopping the medication. Systemic steroids are not generally recommended because of side effects and because of lack of proof of benefit at this time. Since eosinophilic esophagitis is allergy or immune-mediated condition, diet containing common food allergies such as milk, wheat, eggs, nuts should be eliminated as well. A very effective way to treat eosinophilic esophagitis is switching the diet to elemental formula diet, which are free of allergic protein. This diet comes in the form of a special liquid diet in which all proteins are broken down to their simplest building blocks, the free amino acids. For infectious esophagitis, the most common causes are Candida, herpes, and CMV. Those that are at risk for infectious esophagitis are those who are immunocompromised. So those with HIV, patients who have malignancy, especially those with history of chemotherapy, or patients who have undergone organ transplant. Regardless of the infectious agent, the most characteristic symptom in infectious esophagitis is odynophagia or pain during swallowing. Although patients can also experience other symptoms such as dysphagia, chest pain, and gastrointestinal bleeding. Candida is the most common cause of infectious esophagitis. Candida albicans is a normal component of the oral flora, but it can become a problem if the host is immunocompromised. An additional risk factor for Candida esophagitis, aside from being immunocompromised, is esophageal stasis, which can be due to esophageal motor disorders or diverticula. So for Candida esophagitis, you can check the tongue for oral thrush. So you will see here the oral thrush, but you should suspect Candida down to the esophagus if there is odynophagia. And the most useful diagnostic evaluation is endoscopy with biopsy. So endoscopy you will see white plaques or exudates with friability. So the treatment of choice is oral fluconazole that is given for 14 to 21 days. And patients who are refractory to fluconazole may respond to other antifungals such as voriconazole or posaconazole. If there is poor response to these medications, or for patients who cannot swallow medications, they can be treated with intravenous echinocandin. This is the most common viral cause of infectious esophagitis, and most cases are due to HSV1. Again, you check for other body parts like the tongue and oral mucosa for lesions. So the lesions are vesicles. They are fluid-filled, and on endoscopy, you will see these vesicles along with small superficial ulcerations. Confirmation is done by taking biopsies from the ulcer margins and checking for the characteristic ground glass nuclei, eosinophilic Cowdrey type A inclusion bodies, and giant cells. The disease may be self-limited for immunocompetent hosts, although acyclovir can be given. But for patients who are immunocompromised, they are treated with acyclovir, famciclovir, or valacyclovir. Another cause of infectious esophagitis is cytomegalovirus. On endoscopy, the lesions appear as large serpiginous ulcers, commonly in the distal esophagus. During endoscopy, biopsies are taken from the ulcer bases. The pathognomonic findings are large nuclear or cytoplasmic inclusion bodies, or what we call the owl's eye cells. Treatment options are ganciclovir and vanciclovir. Let me now discuss esophageal diseases due to mechanical trauma and iatrogenic injury. Most cases of esophageal perforation are caused by instrumentation to the esophagus or trauma to the area. This includes endoscopy, with the risk being greater in therapeutic endoscopy like dilation, stent placement, endoscopic mucosal resection, and other therapeutic endoscopy modalities. It can also be from surgical procedures, or sometimes even from minor procedures like placement of endotracheal tube or nasogastric tube. Rarely, forceful vomiting or retching can also cause spontaneous rupture at the gastroesophageal junction, and this is known as the Boerhaave syndrome. More rarely, corrosive esophagitis or neoplasms can lead also to perforation. Esophageal perforation causes pleuritic retrosternal pain that can be associated with pneumomediastinum and subcutaneous emphysema. Mediastinitis is a major complication of esophageal perforation. The mediastinum is the central compartment of the thoracic cavity, which contains the heart, the great vessels, the trachea, and the esophagus. The classic triad of symptoms include severe chest pain, vomiting, and subcutaneous emphysema or air under the skin. Later on, there will be fever, chills, chest pain that may be severe and sudden, and shortness of breath. It is very important to detect this condition early on because this condition has a very high mortality rate even with prompt intervention. The quickest way to assess would be by chest x-ray. You can see here the mediastinal air in the chest x-ray of this patient, but the most sensitive in detecting mediastinal air would be CT scan of the chest. Esophageal perforation is confirmed by a contrast swallow using water-soluble oral contrast. Here you can see the contrast leaking out of the esophagus, so that confirms your area of perforation. Once you suspect perforation, nasogastric tube should be inserted carefully and broad-spectrum antibiotics should be started. The treatment options would depend on the extent, the location, and the nature of the perforation. If, for example, the perforation happens during endoscopy, then one option is to close the perforation using hemoclips. Another option is placing a metallic stent across the area of the perforation. But most of the time, surgical management is needed and referral to your surgeon should be made for surgical drainage, possibly debridement and repair of the leaks. The next condition is Mallory-Weiss tear. Vomiting, retching, or vigorous coughing can cause a transmural tear at the gastroesophageal junction. So, this is a common cause of upper GI bleeding. Most patients present with vomiting of fresh blood, and usually this hematemesis is preceded by a non-bloody vomiting. Bleeding usually resolves spontaneously, but persistent bleeding may respond to diluted epinephrine or cauterization therapy, endoscopic clipping, or angiographic embolization. Next, we have radiation esophagitis. Those who are at risk for radiation esophagitis are those who have undergone radiation for thoracic cancers like breast or lung cancers. The risk of having radiation esophagitis is proportional to the dose of radiation received. There are certain radiosensitizing drugs such as doxorubicin, bleomycin, and cisplatin that may also add a risk to the possibility of having radiation esophagitis. Dysphagia and odynophagia may last for weeks to months after treatment. Early on, there may be mucosal erythema, edema, and friability. But in months to years, once this inflammation heals, there may be fibrosis and stricturing. So treatment for acute radiation or acute radiation esophagitis is supportive, but for chronic strictures, it should be managed with esophageal dilation. Caustic injury to the esophagus can be accidental or intentional. Both alkali and acid ingestion can cause injury to the esophagus, although alkali ingestion is more common. Early endoscopic evaluation is recommended, and endoscopy should be done within 24 to 48 hours to assess and grade the injury to the esophageal mucosa. So knowing the extent of the damage based on the endoscopic findings will help us with our management. For example, for low-grade injuries, these injuries generally require only supportive care, and you can advance to a regular diet within a few days. But for high-grade injuries, these necessitate more intensive management and close observation. Healing of more severe grades of caustic injury is commonly associated with severe stricture formation later on, and these are the ones that would require dilation later on. Initial endoscopy after 48 hours of ingestion is not advised because the injured esophagus may then enter at this time the phase of ulceration and granulation, and this is the time when the esophagus becomes very fragile and can easily be perforated. Severe corrosive injury may lead to esophageal perforation, bleeding, stricture. So this is an example of a stricture months to years after the ingestion, and it can also lead to death. Pill-induced esophagitis occurs when a swallowed pill fails to traverse the entire esophagus and lodges within the lumen. The most common location for the pill to lodge is in the mid-esophagus, near the crossing of the aorta and the carina. This leads to chemical irritation in the mucosa as the drug is dissolved in this area. Generally, this is attributed to poor pill-taking habits, such as inadequate liquids, lying down immediately after taking a pill, And a variety of medications are often implicated with pill esophagitis, with the most common being antibiotics such as doxycycline, tetracycline, some are NSAIDs, and some are ferrous sulfates or other medications. Symptoms of pill esophagitis occur within hours or days after taking the pill. The most common symptoms are the sudden onset of chest pain and odynophagia. And when endoscopy is performed, there is localized ulceration and inflammation in the area where the pill was lodged. There's no specific therapy that is known to hasten the healing process, but anti-secretory medications such as PPIs are frequently prescribed to remove concomitant reflux as an aggravating factor. Aside from pills, food or foreign body may also lodge in the esophagus. If there is complete obstruction, the patient may be unable to handle secretions, and so you will see foaming at the mouth and alongside with severe chest pain. If this is not resolved, then endoscopy with extraction of the foreign body may be performed. So in these pictures, we have food being taken out using a roughnecke, and here dentures being removed using a basket extractor. So after endoscopy, it is warranted to check for possible causes. No, we have to check if there are areas of narrowing such as strictures, and we have discussed also the natural constriction on the mid-esophagus, but sometimes there can be narrowings or strictures due to other causes like benign strictures, maybe masses, or eosinophilic esophagitis. And lastly, for esophagus, remember that esophageal disease can be just a part of a systemic disease. Among them are connective tissue disorders such as scleroderma and some other dermatologic conditions. Our next topic is peptic ulcer disease and related disorders. First, let's define peptic ulcer disease. A lot of patients would come to the clinic and say they have an ulcer, and when you ask why do you think they have an ulcer, they would reply, because I have frequent epigastric pain. Well, that is a common misconception, because having symptoms of a probable ulcer or dyspepsia is not actually synonymous with peptic ulcer disease. Peptic ulcer is defined in Harrison's as disruption of the mucosal integrity of the stomach and or duodenum, leading to a local defect or excavation due to active inflammation. According to the American College of Gastroenterology, an ulcer is an open sore, and the word peptic means that the cause of the problem is due to acid. And locally, the Philippine Society of Gastroenterology defines ulcer as an open sore in the stomach or duodenum which could cause abdominal pain and bleeding. Peptic ulcer disease can be located in the stomach or in the duodenum, and these are some of the differences between duodenal ulcer and gastric ulcers. First, of course, is the location. Duodenal ulcers are almost always located in the duodenal bulb. But the most important difference is that malignant duodenal ulcers are extremely rare, while gastric ulcers can represent a malignancy or may at least be a risk factor for malignancy later on. And this is the reason why we take biopsies on gastric ulcers and do surveillance endoscopy later in gastric ulcers, while we don't take biopsies in duodenal ulcer and we do not need to do surveillance endoscopy. Another difference is that while patients with duodenal ulcers have increased basal and nocturnal gastric acid secretion, those with gastric ulcers actually have normal or even decreased gastric acid output. So what does this mean? It means that in gastric ulcer, the problem is probably more of impaired mucosal defense. This is just a review. You've learned this in your physiology class. So central to the physiology of gastric secretion is the parietal cells. So the parietal cells are usually found in the neck or the isthmus or in the oxyntic gland. On the left is the resting parietal cell, and this is how parietal cells are when stimulated by gastrin, acetylcholine, and histamine. So there is activation of the hydrogen potassium ATPase pumps or proton pumps, and this is the final common pathway which secretes hydrogen and chloride into the gastric lumen to form hydrochloric acid. This is important because this is what proton pump inhibitors like omeprazole or esomeprazole block in order to inhibit acid secretion, and these PPIs are now considered to be the most potent medications for lowering gastric acid. Aside from the proton pumps in the parietal cells, acid secretion is also regulated by nerves, hormones, and other local cells. The vagus nerve sends signals via acetylcholine, VRP, or GRP to promote acid secretion. Again, the parietal cells are the most important, and it is directly stimulated by acetylcholine. Now, aside from the parietal cells, the other major stimulators are the G cells, which make gastrin. This is a hormone that strongly promotes acid secretion, and the enterochromaffin cells. This releases histamine, which then activates parietal cells via the H2 receptors. This is actually the pathway by which the H2 receptor blocking agents act. There are some which inhibit acid secretion, and the most important are the somatostatin from the D cells. Somatostatin inhibits G cells, ECL cells, and the parietal cells, and this inhibition is important to maintain balance. Whether an individual will end up having peptic ulcer disease or not would depend on the balance between the defensive factors and the aggressive factors that are present in that individual. So the first line of defense is the mucous bicarbonate layer. This provides physical and chemical barrier that neutralizes acid at the mucosal surface. Next, we have the mucosal blood flow. This provides bicarbonate, which neutralizes the acid that is generated by the parietal cells. And it also delivers micronutrients and oxygen and removes toxic agents. And next, we have the prostaglandins. These molecules are crucial for maintaining mucosal integrity because they stimulate mucus and bicarbonate secretion, they increase mucosal blood flow, and promote cell renewal. So if the aggressive factors overcome the defensive factors, then peptic ulcer disease can occur. The two major factors that are associated with peptic ulcer disease are H. pylori and the use of nonsteroidal anti-inflammatory drugs. The others are additional risk factors. In fact, if an ulcer is neither associated with H. pylori or NSAID use, it is considered as idiopathic peptic ulcer disease. So these are the other risk factors. Helicobacter pylori or H. pylori is the most important worldwide risk factor for peptic ulcer disease. This bacterium is responsible for 90% of duodenal ulcers and around 70 to 90% of gastric ulcers. So this is a spiral-shaped gram-negative bacterium. This spiral shape, along with its flagella, enable it to penetrate the mucous layer of the stomach. The usual area that is affected is the antrum. It is more prevalent among those with lower socioeconomic status. The mode of transmission is through oral-oral or fecal-oral route, and it is a risk factor for gastric cancer. either multiple lymphoma or adenocarcinoma. The next most important factor in peptic ulcer disease is the use of non-steroidal anti-inflammatory drugs. So examples of this are mefenamic acid, ibuprofen, diclofenac, naproxen, and those with less gastric irritation are COX-2 inhibitors like celecoxib and etoricoxib. Aspirin is both an anti-inflammatory and an antiplatelet, so this is used for cardioprophylaxis. Now, despite the fact that NSAIDs are used left and right, being mostly an over-the-counter drug, not all patients who take NSAIDs have peptic ulcer disease or have bleeding related to peptic ulcer disease. So those who are at risk for this would be those with advanced age, those with previous history of ulcers, those with concomitant use of glucocorticoids, high-dose NSAIDs, multiple NSAID use, those with concomitant use of anticoagulants or clopidogrel, those with serious or multisystem disease. So we should always look for these risk factors. NSAIDs work by inhibiting cyclooxygenase enzymes. Since most NSAIDs inhibit both COX-1 and COX-2, they are very effective as pain relievers and anti-inflammatory because they block the production of prostaglandins. But then the role of prostaglandins in the defense against peptic ulcer disease was explained a while ago. They stimulate mucus and bicarbonate secretion, they increase the mucosal blood flow, and they have a role in epithelial repair. So when prostaglandins are inhibited, the defense of the GI tract is also impaired. So there will be erosions or ulcers, and this can be accompanied by complications such as bleeding. H. pylori and NSAIDs are involved in majority of PUD cases that if neither H. pylori or NSAID is involved, we look for other possible factors. Smokers have been found to have ulcers more frequently than non-smokers, and the risk of PUD increases with increasing pack years of smoking. There are also studies that suggest that individuals with a family history of peptic ulcer disease are also more likely to develop ulcers. Individuals with type O blood also have an increased risk for peptic ulcer disease. This is likely due to H. pylori preferentially binding to group O antigens, so they have more susceptibility to colonization with H. pylori. As for the diet, we know that certain food and beverages, such as spicy and fatty food, citrus, among others, can cause symptoms of dyspepsia, but there are no convincing studies that directly implicate these types of diet to ulcer formation. There's also no evidence that coffee consumption is a risk factor for peptic ulcer disease, although we know that it can trigger symptoms. And lastly, specific chronic disorders have also been shown to have strong association with peptic ulcer disease. So among them are COPD, chronic renal failure, cirrhosis, and others. Other less common causes of peptic ulcer disease are shown in this table. So some here are infections, some are medications, and some other conditions. The most prominent symptom for peptic ulcer disease is epigastric pain or epigastric discomfort, and this is often described as burning or gnawing discomfort. Patients usually also complain of abdominal bloating and nausea as well as early satiety. It is also important to note that 70% of patients with peptic ulcer disease have none of these symptoms, especially those caused by NSAIDs. So they might not have the usual symptoms of pain, but they might present already with a complication, and most often this is gastrointestinal bleeding. As for the physical examination in general can be normal, or sometimes there can be tenderness in the epigastric area. In general, complications of peptic ulcer disease occur more often in individuals at least 60 years old. Bleeding is the most common complication of peptic ulcer disease, and this is usually in the form of black tarry stools or melena. That's why when we have patients with suspected peptic ulcer disease, one thing we never fail to ask is if his stools are black, because this is an alarm symptom that needs further investigation. Sometimes the bleeding may be massive, and instead of melena, patients may present with fresh blood stools or hematochezia. And when hematochezia is the presentation of patients with suspected upper GI bleeding, there is usually accompanying signs of hemodynamic instability like hypotension, tachycardia, or orthostatic hypotension. The 30-day mortality rate for patients with bleeding peptic ulcer is 2.5 to 10%. You don't need to memorize this. This is just to show you that for cases of gastrointestinal bleeding, we use the Forest classification based on endoscopic findings to guide us in the management. For example, the ulcer on endoscopy is clean-based. No, you have a clean-based ulcer or Forest 3. This means that we can just give oral proton pump inhibitors and send the patient home, as compared if the lesion is actively bleeding like Forest 1A or 1B, which means that there is a high risk of rebleeding and that we should do endoscopic therapy and give high-dose PPI intravenously. The second most common ulcer-related complication is perforation. This can be seen in 6 to 7% of patients with peptic ulcer disease, but the estimated 30-day mortality rate is higher than that of bleeding at more than 20%. Patients usually present with the triad of acute abdominal pain, tachycardia, and abdominal rigidity. Elderly patients are more at risk for perforation because of increased use of NSAIDs and also cardiovascular drugs. In perforation, there is spillage of the gastric contents into the peritoneal cavity, and this will cause peritonitis, which is a surgical emergency. Penetration is a form of perforation in which the ulcer bed tunnels into an adjacent organ. In contrast to perforation, there is no leakage of luminal contents into the peritoneal cavity, but still this is a condition that warrants surgical management. So here you can see a gastric ulcer penetrating into the pancreas. So this is just an example, but it is actually the duodenal ulcers that tend to penetrate more posteriorly into the pancreas, whereas gastric ulcers tend to penetrate to the left hepatic lobe. Gastric outlet obstruction occurs in 1 to 2% of patients with peptic ulcer disease. Ulcers can cause gastric outlet obstruction if there is inflammation and edema in the peripyloric channel or duodenal region. If this is due to acute inflammation or edema, this can be treated medically. But if this is due to scarring or fibrosis of an ulcer, then endoscopic dilation or surgery should be performed. Symptoms are often due to the inability of food and gastric contents to pass through this area. So the most prominent symptom would be vomiting of previously ingested food. But there can also be early satiety, nausea, increase in postprandial abdominal pain, and weight loss. If an individual presents with ulcer-like symptoms and all workup turn out negative, then we can diagnose the patient as having functional dyspepsia. This is a functional disorder of the upper gastrointestinal tract. And by functional, I mean that there is no structural abnormality. This means that you have already ruled out other differential diagnoses, either by endoscopy and by imaging. So, functional dyspepsia is more of a diagnosis of exclusion. If the primary presentation is epigastric or burning pain, then it's probably epigastric pain syndrome. If the primary symptom is postprandial fullness or early satiety, then it's postprandial distress syndrome. This is important because patients with epigastric pain syndrome may benefit from proton pump inhibitors, while those with postprandial distress syndrome may benefit from prokinetics. Barium studies used to be the diagnostic modality of choice, but this is no longer used for peptic ulcer disease because nowadays the method of choice is endoscopy. Endoscopy provides the most sensitive and specific approach for examining the upper GI tract. Through endoscopy, we can directly visualize the mucosa, we can document our findings, and we can take biopsies to rule out malignancy or to check for H. pylori. So this is how an ulcer appears on endoscopy. Not all patients presenting with peptic ulcer disease need an endoscopy. Age is one factor to consider. So the American Society of Gastroenterology recommends endoscopy for uninvestigated dyspepsia if the patient is at least 50 years old. Some would do it at age 40 years old. So the range is usually between 40 to 55 years old. But regardless of the age, the presence of at least one alarm symptom is already an indication for endoscopy. So if your patient presents with dysphagia, dinophagia, weight loss, gastrointestinal bleeding, persistent vomiting, or unexplained iron deficiency anemia, and probably an additional alarm symptom would be family history of gastric cancer. If the patient has any of this, even if he is young or below the cutoff age, then endoscopy should be performed. For H. pylori testing, we have invasive tests which requires endoscopy and biopsy. So the sensitivity and specificity for rapid urease tests are very high at 90 to 95%. For rapid urease test, the specimen is taken during endoscopy and the result can be seen within an hour or at the most 24 hours. The histology is usually not done unless the rapid urease test is not available, and the culture is done only if you suspect resistance to antibiotics. There are three types of non-invasive tests that can be used. We have the serologic testing, we have the urea breath test, and the H. pylori stool antigen test. Among these, the urea breath test and the stool antigen test are more helpful because active H. pylori infection can be detected using these methods. More importantly, these two tests, again, urea breath test and stool antigen test, are the best options to check for eradication of H. pylori. So after treatment with antibiotics and PPI, we can check after several weeks if the H. pylori has been eradicated using H. pylori stool antigen test or urea breath test. These are the treatment options for peptic ulcer disease. For acid neutralizing drugs, we have antacids, H2 receptor antagonists. We have proton pump inhibitors. These are the most potent acid inhibitors at this moment. And we have the newest class of acid neutralizing drugs, the potassium competitive acid pump antagonist or the potassium channel blockers. So for antacids, these acid neutralizing drugs are mainly used for symptomatic relief of dyspepsia. They do not promote mucosal healing like the H2 receptor antagonists or the proton pump inhibitors. Their onset of action is quick, so you have rapid relief of pain, but the effect is also short term, so you would need frequent dosing. For these medications, it is better used as on an as needed basis, especially if the attacks are not that frequent. So examples of this are aluminum hydroxide, but they found out that these can produce constipation and phosphate depletion. You also have magnesium hydroxide, which may cause loose stools, so they combine these two to avoid the side effect of the constipation and the diarrhea. So many of our popular antacid brands are a combination of aluminum hydroxide and magnesium hydroxide. Just a precaution, in patients with CKD or chronic kidney disease, aluminum may cause chronic neurotoxicity in these patients, while magnesium hydroxide can cause hypermagnesemia in these patients. So better be cautious when giving them to patients with chronic renal failure. Another form of antacids are a combination of calcium carbonate and sodium bicarbonate. So we also have popular brands here with these combinations. The long-term use of calcium carbonate can lead to milk alkali syndrome. So you can have hypercalcemia, hyperphosphatemia with possible renal calcilosis, and this can progress to renal insufficiency later on. And sodium bicarbonate may induce systemic alkalosis. H2 receptor antagonists. So examples of this are ranitidine and famotidine. These drugs used to be the drugs of choice for peptic ulcer disease before PPIs were discovered. As the name implies, H2 receptor antagonists block histamine H2 receptors on gastric parietal cells. This inhibits histamine-stimulated secretion of gastric acid, reducing both the basal and meal-stimulated acid output. As with all other medications, H2 receptor antagonists have side effects. But aside from the side effects, the main problem actually with this is if you give it for a long period of time, individuals will eventually develop tolerance to the drug. So it will not be as effective in the long run. And we know that patients with peptic ulcer disease may need medication for months, and some even need them indefinitely. So for now, the use of H2 receptor antagonists is mainly as an add-on if PPIs fail to control the symptoms. Next, we have proton pump inhibitors. So the commercially available PPIs are omeprazole, lansoprazole, rabeprazole, pantoprazole, esomeprazole, and dexlansoprazole. PPIs at present are considered as the most potent acid inhibitory agents. So this was discussed a while ago. This is the parietal cells when stimulated, and the final common pathway of acid secretion is the activation of the hydrogen potassium ATPase or the proton pump. And blocking this using proton pump inhibitors is the best way to inhibit acid secretion. And for the past years, it has been proven to be a powerful tool for long-lasting acid suppression. Long-lasting because, for one, the duration of acid inhibition lasts 72 to 96 hours. And second, even if we give it for months or years, there's no problem regarding tolerance to the drug. The onset of action of PPIs is a bit slower than antacids, with a maximum acid inhibitory effect between 2 and 6 hours after administration. So for rapid relief, it would be more appropriate to give an antacid rather than PPIs. And because the pumps need to be activated for these agents to be effective, their efficacy is maximized if they are administered before a meal. Next is the potassium competitive acid pump antagonists, or PCAP, or simply potassium channel blockers. This is the newest class of acid neutralizing drugs. Their mechanism is somewhat similar to PPIs because they also block the hydrogen potassium ATPase in the parietal cell. But unlike the PPIs, they do so by competing with potassium ions at the binding site. So no exchange happens and no hydrochloric acid is released. The PCAPs that are available now in the Philippines are vonoprazan, tegoprazan, and fexuprazan. And so far, some studies have shown better acid suppression than PPIs, and it has also been approved in the treatment of H. pylori. But this is still a very new drug, so we have to wait for more studies. Cytoprotective drugs are not acid-suppressing drugs. Instead, they form a physical protective barrier over the ulcer. So some examples are sucralfate, bismuth-containing preparations, and prostaglandin analogs. Sucralfate is a complex of sucrose sulfate and aluminum hydroxide. It becomes a viscous paste within the stomach and duodenum, binding primarily to sites of active ulceration. So the mechanisms by which sucralfate acts are, they act as a physicochemical barrier, they enhance prostaglandin synthesis, they stimulate mucus and bicarbonate secretion, and they enhance mucosal defense and repair. The most common side effect is constipation, although there have been reports of aluminum-induced neurotoxicity, specifically in patients with chronic renal insufficiency, as well as hypophosphatemia and gastric bezoar formation. The mechanism by which bismuth-containing preparations induce ulcer healing is unclear, but it definitely has a role in H. pylori treatment, which will be discussed later. Colloidal bismuth subcitrate and bismuth subsalicylate are the most widely used preparations, and the adverse effects with short-term use include black stools, constipation, and darkening of the tongue. Now for the prostaglandin analogs. Prostaglandin is one of the defensive factors against peptic ulcer disease. It does so by stimulating mucus and bicarbonate secretion. It promotes mucosal blood flow and repair. And so when the prostaglandins are reduced, like during NSAID use, the mucosa become vulnerable to injury and ulcerations form. And so, prostaglandin analogs can be used to enhance mucosal defense and repair, especially against NSAID-induced peptic ulcer disease. The most common toxicity known is diarrhea, but the other major toxicity includes uterine bleeding and contractions. So this is contraindicated in women who may be pregnant or those who want to get pregnant. And in fact, this complication is the reason why this drug has been under regulation. It has been abused by some individuals who use them for abortion. H. pylori is the most common risk factor for peptic ulcer disease. And giving PPIs alone will eliminate the symptoms, yes. It will even promote ulcer healing. But if you don't eliminate the cause, which is the H. pylori bacteria, then chances are the condition will just recur. This happens in 67% of duodenal ulcers and 59% of gastric ulcer patients when the organism is not eliminated. So the consensus among the different societies is that H. pylori should be eradicated in patients with documented peptic ulcer disease. Why? Because H. pylori is a known carcinogen. It is a risk factor for gastric cancer. So aside from the fact that it's the most common cause of ulcers, it can also lead to gastric CA, malt lymphoma, and eradicating H. pylori can help prevent this. So the next question would be when to treat asymptomatic patients. So we treat asymptomatic patients if there is high risk for gastric CA. So if you have a family history, if the patient lives in a location with a high prevalence of gastric CA, we treat asymptomatic patients with H. pylori if there are precancerous lesions such as atrophic gastritis or intestinal metaplasia, or if the patient has multiple lymphoma. These are the recommended first-line treatment for H. pylori infection. There's no single agent that is effective in eradicating the organism. So it's always a combination of acid suppressants and antibiotics. And usually a combination of therapy for 14 days provides the greatest efficacy. So please go over this table. When we deal with peptic ulcer disease, even if it's not yet clearly established what the cause is, it is imperative to stop all possible causes, and NSAID is one of the most common. Once you suspect PUD, you can immediately start your PPIs. If you can stop the NSAID, then that's good. But if for some reason the NSAID cannot be stopped, for example, aspirin is needed to be continued because of high risk of a cardiac event, we start PPIs anyway. So only PPIs can heal gastric ulcers or duodenal ulcers independent of whether NSAIDs are discontinued. For prophylaxis, for example, if you have to give NSAIDs in a patient with a history of peptic ulcer disease, PPI is still the drug of choice, although misoprostol can be another option. For these patients, we can also opt for COX-2 inhibitors because they cause less gastric irritation than the standard NSAIDs. So examples of this are celecoxib or etoricoxib. And even if the patient with PUD has a history of NSAID use, which predisposes them to PUD, we still check for H. pylori and we treat if it's positive. I've mentioned that COX-2 inhibitors have less GI risk as compared to traditional NSAIDs, and that makes them a good choice for all patients with peptic ulcer disease, right? Well, not exactly, and here is why. There were studies before that certain COX-2 inhibitors like rofecoxib and valdecoxib, both of which have been pulled out of the market, increases the risk of cardiovascular events and stroke. And for this reason, we also consider not just the gastrointestinal risk in choosing the NSAIDs, but also the cardiovascular risk of the patients. So if there is no cardiovascular risk and there's no GI risk, then traditional NSAIDs can be used. If there is no cardiac risk, but there is a gastrointestinal risk, we can use COX-2 inhibitors, traditional NSAIDs plus PPI or misoprostol, or maybe consider other options for pain. For those patients with severe risk, COX-2 inhibitors are not recommended. So we use either traditional NSAIDs and add proton pump inhibitors, or consider other options instead of NSAIDs. So when we have patients with suspected peptic ulcer disease, first we consider the age of the patient. Again, the age is controversial, so it's somewhere between 40 to 55 years old. We also check for alarm symptoms. So if it's negative for both, we can do non-invasive H. pylori testing, and if it's positive, we treat for H. pylori and then we confirm eradication. If the H. pylori is negative, we can give a trial of actually proton pump inhibitors and not H2 blockers. So if persistent, we refer to a gastroenterologist. Also, if there are alarm symptoms, even if the patient is young, we already refer to a gastroenterologist, and the gastroenterologist is expected to perform endoscopy and get biopsies for H. pylori during the endoscopy. Of course, on EGD, we can visualize if the patient indeed has peptic ulcer disease. If none, then it is likely a functional disorder. Since gastric ulcer can represent a malignancy or at least have a potential to be malignant, patients with confirmed gastric ulcer, especially those found in the body and fundus, should undergo a repeat endoscopy at 8 to 12 weeks to document healing. Whereas for patients with duodenal ulcers, repeat endoscopy is warranted only if symptoms persist despite medical treatment or if a complication is suspected. A gastric ulcer that fails to heal after 12 weeks and a duodenal ulcer that does not heal after 8 weeks of therapy should be considered refractory. In these cases, we check for compliance to medications and we check also for risk factors such as NSAIDs. These are the 3 PUD-related conditions that we will discuss. Again, if we encounter gastric ulcers and duodenal ulcers that are refractory to treatment, we consider other conditions. And one of the conditions that we should check is the Zollinger-Ellison syndrome. This condition is characterized by marked gastric acid hypersecretion that is caused by gastrin-secreting neuroendocrine tumors or gastrinomas, and these are usually located in the pancreas or the duodenum. This is a rare disorder occurring in only 0.1 to 1% of patients presenting with peptic ulcer disease. Peptic ulcer is the most common clinical manifestation, occurring in more than 90% of gastrinoma patients. So when ulcers occur in atypical sites, especially if they're refractory to treatment, or they occur in the absence of the usual culprits like H. pylori or NSAIDs, maybe we should consider the possibility of ZES. Diarrhea is the next most common clinical manifestation and is found in up to 70% of patients. This may result from marked volume overload in the small bowel, pancreatic enzyme inactivation by acid, and damage of the intestinal epithelial surface by acid. If you will notice, there was never a mention of diarrhea throughout the course of this lecture because diarrhea is not a usual symptom of peptic ulcer disease. So if a patient presents with symptoms of epigastric pain consistent with PUD but associated with diarrhea, then maybe you should think out of the box and consider less common conditions such as ZES. Gastrinomas are classified into sporadic tumors and those associated with multiple endocrine neoplasia or MEN type 1. So this is an autosomal dominant disorder which involves 3 organ sites. We have the parathyroid glands, the pancreas. The first step in the evaluation of a patient suspected of having ZES is to obtain a fasting gastrin level. The normal fasting gastrin levels are usually less than 150 picogram per ml. This is the first step because if you have a gastrin level of less than 150, then you have already ruled out ZES. If the value is 150 to 200, we still have to proceed with basal acid output or secretin stimulation test. This is because conditions other than CES can also cause elevated fasting gastrin levels. Basal acid output can be measured using endoscopy or through nasogastric aspiration. So the normal BAO is 4 to 5 megs per hour. And if the BAO is more than 15 megs per hour in the presence of hypergastrinemia, this is considered pathognomonic of ZES. The most sensitive and specific gastrin provocation test for the diagnosis of gastrinoma is the secretin study. So an increase in gastrin of more than 120 pg within 15 minutes of secretin injection has a sensitivity and specificity of more than 90% for Zollinger-Ellison syndrome. When biochemical diagnosis of ZES is already confirmed, so you have an elevated gastrin, you have a positive secretin test, then the next step would be tumor localization or staging. Both MRI and CT scan are fairly reliable and are readily available, especially the CT scan. So they are the logical first step in checking for metastasis. If available, the octreotide scan would even be a better option than CT or MRI. So this is a nuclear medicine imaging test that uses radio-labeled somatostatin analog. And more recently, the PET-CT has emerged as the functional imaging study of choice, not just for gastrinoma, but also for other neuroendocrine tumors, if this is available. Some studies have already shown that it is superior to octreoscan for localizing gastrinomas and detecting metastases in ZES. And for primary gastrinoma, you will notice that the EUS has the highest sensitivity. And this is probably because the most common site is the pancreas, and when endoscopic ultrasound is done, it is really in close proximity to the pancreas, so the sensitivity is really very good. The goals of treatment in ZES are to control the symptoms, curative resection of the tumor, and control tumor growth in metastatic disease. So the PPIs are still the treatment of choice in controlling the symptoms of ZES. The use of PPIs have decreased the need for total gastrectomy, and initial PPI doses tend to be higher than those used for the treatment of GERD and peptic ulcer diseases. Somatostatin analogs like octreotide has also been used as an adjunct if the simples are difficult to control with the high-dose PPIs. And although these medications can control the symptoms, the definitive cure is still curative resection of the tumor, so surgery is still warranted. For those with sporadic disease, 95% of patients will remain disease-free after 10 years. But for those associated with MEN1, the role of surgery is actually controversial because you have other areas affected as well. So in these cases, only less than 5% of patients will remain disease-free after 5 years. Now, the approach for patients with metastatic disease are not really well defined. We can try to control the symptoms using PPIs and somatostatin analogs, maybe offer chemotherapy, targeted therapy. Some would perform surgery like tumor debulking. But at the end of the day, we still consider what is best for these patients. So for these patients, especially with hepatic metastasis, which is the most common, they have less than 20% survival at 5 years. The next PUD-related condition that we're going to discuss is stress-related mucosal injury. These are acute erosions and ulcerations in the stomach, especially in the fundus and body or in the proximal duodenum. This is commonly seen in patients with severe physiologic stress, such as those suffering from shock, sepsis, massive burns, severe trauma, or head injury. The most common presentation is gastrointestinal bleeding. So upper GI tract is the source of bleeding. It's usually black tarry stools or melena. Respiratory failure requiring mechanical ventilation and underlying coagulopathy are risk factors for bleeding, which tends to occur 48 to 72 hours after the acute injury or the insult. We have special types of stress-related mucosal injury. We have Cushing's ulcer for those with head trauma and Curling's ulcer for those with severe burns. Whatever the cause is, PPIs are still the treatment of choice for stress prophylaxis. So if we see patients that are at risk for stress-related mucosal injury, we can start PPIs. Fortunately also, bleeding in stress-related mucosal injury is usually minimal and it can stop with PPI, although at times we also need to perform endoscopic therapy for those who do not have a response to proton pump inhibitors. The term gastritis is another one of those terms that patients use often, like the term ulcer. A lot of times they use it interchangeably with dyspepsia. The term gastritis is actually a histologic diagnosis. So gastritis is for biopsy-proven inflammation of the gastric mucosa. In general, gastritis can be acute or chronic. Acute gastritis presents with sudden onset of epigastric pain, nausea, and vomiting. It can last for days to weeks, and the most common cause is H. pylori bacteria, and less common are other infections or probably medications. On biopsy, there is marked infiltrate of neutrophils with no or minimal gland atrophy. It is usually self-limited, but sometimes it can also cause gastrointestinal bleeding. So if you don't treat acute gastritis, it can evolve into chronic gastritis. So this can be seen after several months or several years. And in contrast to acute gastritis, the biopsies will show inflammatory cell infiltrate consisting primarily of lymphocytes and plasma cells with very few neutrophil involvement. And there is also atrophy of the glands. So in the early phases, the inflammatory changes are limited to the lamina propria of the surface mucosa. And then later on, the inflammatory infiltrate extends deeper into the mucosa, and there will be distortion and destruction of the glands, or what you call atrophic gastritis. As the condition progresses, glandular structures are eventually lost. So you have gastric atrophy, and we recognize this on endoscopy as having a thinned out mucosa wherein we can see the underlying vessels more clearly. The atrophic mucosa then undergoes intestinal metaplasia, which is an important predisposing factor for gastric cancer. There are two types of chronic gastritis. We have type A and type B. Type A is the less common of the two forms, and it involves the proximal stomach. So the body and the fundus are affected, and it spares the antrum. It is caused by autoimmune destruction of the parietal cells. So you have loss of acid and intrinsic factor, and this can lead to pernicious anemia or vitamin B12 deficiency. The parietal cell containing gastric gland is preferentially targeted in this form of gastritis, and achlorrhea results. Type B gastritis is H. pylori related, so it is more common than type A. It is antral predominant, but unlike the type A gastritis, where the common site is the gastric body and the antrum is spared, in this type, the type B, the body and fundus may also be involved later on. So pangastritis is not unusual, but it would take several years, around 15 to 20 years. And as we all know, infection with H. pylori is also associated with the development of gastric multilymphoma and adenocarcinoma. Treatment in chronic gastritis is aimed at the sequelae and not the underlying inflammation. Eradication of H. pylori is often recommended even if PUD or low-grade multilymphoma is not present. Patients with pernicious anemia will require parenteral vitamin B12 supplementation, and we should always monitor the CBC and the B12 levels. And we should also do periodic endoscopy every 3 years for those patients with atrophic gastritis complicated by intestinal metaplasia, and this is to check for dysplasia and carcinoma. And I think this is my last slide.